Hello, everyone, and welcome back to part two of my Mormon Stories podcast interview with Dr. Dan Lonergan. It's October 10th, 2017, 4:20 p.m. Mountain Time, and we had a wonderful first hour and a half talking to Dr. Dan about his upbringing in the church, his mission, his time at BYU, his faith crisis as he was in med school and as a seminary teacher, leading to his departure from the church after the November 2015 policy and after struggling with teaching Mormonism to his seminary students. He also gave us a lot of great tips and experiences on navigating a mixed faith marriage. His wife is a progressive, nuanced Mormon, but he no longer describes as sort of a Mormon believer. But we've talked about how they've made that work, how they've always put family first, and how they've navigated some of the most difficult common challenges for people in a faith crisis. So it's a wonderful first part. For those who haven't listened to it, it's definitely worth listening to. Dan even talks about how he's reclaimed some of his own spirituality after identifying as an agnostic. So it's cool. Check out that interview. Now we're going to do part two, where we talk about addiction, and we're going to be talking about it from the standpoint of an expert, because this is what you do for a living. So if it's okay, as we begin, where should we start in terms of our discussion about addiction? I think I have, for the first part, just to ask you about the most common ways that people get addicted. So, you're going to be talking about a biological component, the sort of the brain and how it works, maybe if there's any genetic components or situational components to the development of addiction, etc. So why don't you just talk about the model for how people oftentimes get addicted?
Sure. So 50% of your tendency to become addicted is genetic. So if your parents are alcoholics, then you have significantly more risk to developing an addiction. So 50% of your tendency you can't even control. And now you can control your exposure and you can control your environment, but the genetic aspect you're stuck with. Then
and that's
there's
about 50%.
50%. Right.
That makes taking any drug almost like Russian roulette, because there are things you can control, but there are some things that are out of your control. And oftentimes I'll have 99 people tell me, oh, now I just drink an occasional beer, an occasional glass of wine, or occasionally smoke some marijuana, and it's never been a problem. I've never become addicted. It's become this healthy, normal thing. And that's the experience for the majority of post-Mormons or liberal Mormons that I talk to. And then there's sort of one out of what? Would you say 100? What would you say? Do you even have a sense for the percentage of people that start drinking alcohol or start experimenting with drugs that become addicted? Is there even a way to estimate?
It's different with different drugs. So specifically with opioid addiction, which is more of my expertise, 1 out of 5 people are at significant risk of developing an addiction. So if I just take a random sample of people off the street and I expose them to a pain pill, 20% of those, 1 out of 5, are going to have significant risk of developing an addiction from that point.
Just imagine playing Russian roulette with 5 chambers. That's what you're talking about, right?
Right. That's exactly what we're talking about.
That makes opiates extremely serious.
True.
And I'm talking about prescription opiates, not heroin. That's serious too, but I'm also talking about prescription opiates.
Which is why the government is being so aggressive. State and federal governments are being so aggressive at limiting exposure. So they're limiting, they're basically cracking down on doctors. And this isn't necessarily going to curb the modern epidemic, but it prevents a future epidemic.
Right.
They're trying to keep it from getting worse.
Got it.
And they're trying to prevent exposure so we don't add more addicted patients to the mix.
Do you have a
So,
sense for the prevalence of alcohol, or the risk of alcohol addiction? Do you even know the number on
so
that?
alcohol is a totally different animal because alcoholism tends to take decades to develop, right? So oftentimes people are exposed as teenagers and then they're heavy drinkers during college, and they're kind of setting up this path to becoming an alcoholic. And a lot of times we'll look at, college kids and we'll be like, I think he's going to be an alcoholic someday, right? But they're not necessarily an alcoholic now. It's just that they're kind of following that path. And it does take, a lot of times people don't really develop heavy alcoholism until their fourth or fifth or sixth decade, right? So it's a lot different than a drug like oxycodone or heroin, where you become addicted very fast. And especially drugs like cocaine, stimulants, methamphetamines, you can become addicted with just a single exposure. So that, it's apples and oranges. Alcoholism is a whole different animal. If you're a very responsible drinker and you don't start till, in your 20s, and you're not heavily drinking, the chances that you're going to become an alcoholic are pretty slim.
Okay. And is it worth talking about marijuana right now, just in terms of genetic or other sorts of, rates of risk?
Yeah, I mean, I think marijuana is going to fall it's not in the extreme spectrum that opiates or stimulants are going to fall in. Clearly, marijuana is much safer and there's much less risk. In fact, there's hardly any risk of fatal overdose from marijuana. So the problem with marijuana, it's so politically charged that it's hard to even have a good discussion about, a good scientific discussion about it. And as a disclaimer, I'm not a marijuana expert.
Sure.
It's not legal in Tennessee, so it's not something that I prescribe. It's not something I recommend for patients. But I do want to be clear that marijuana is not dangerous from a fatality standpoint like pain pills are, like opiates are. Opiates are extremely dangerous drugs and are killing people by the tens of thousands. Marijuana is not killing people. I mean, there might be like circumstantial, cases where, someone might drive under the influence and it becomes fatal in that way. But you're not reading about people dying of marijuana overdose.
And so I've heard a lot of cannabis advocates say that marijuana is way safer than alcohol too. Is that true in your experience?
I don't have any data that I have pulled up where I can make a statement either way, but I'd say I would put them as fairly equivalent. So, I don't know if one is safer than the other, but I wouldn't be that surprised, if that were the case.
I've heard that, you don't use marijuana usually and become violent. Marijuana doesn't impair your driving like alcohol does, as I've heard. I've never tried it, so I'm just speaking from the people that I've spoken with. And it doesn't have the risks of addiction that alcohol would. What would
Yeah,
you say about that?
I would say that's probably fairly controversial, and I'm not sure it's just not my area of expertise.
Okay,
So I'm
that's
not
fine.
really.
That's fine. That's fine. Okay, so somebody asked, how far back does that genetic link go? So let me ask that in a different way. How do you identify whether or not you have a family history, and what's a family history that's kind of noteworthy versus not?
Well, the closer the relative, the more relevant it is. So if it's a brother or sister or a parent, then it's going to be a lot more relevant than an aunt or an uncle, or the further removed you get, the less relevant it is. But your DNA is your DNA. The point of saying that a lot of this is genetic, some people just don't have the tendency in their DNA to feel good after taking a pain pill. So a lot of my patients don't like the way pain pills make them feel. That's why a lot of patients come to see me, because they know that I do other things than pain pills, that's not really my focus. So if you're just not genetically hardwired to have that euphoria and to have that addiction component, then it's probably just not going to happen to you. But most people will know with opiates based upon the experience they've had after surgery. If you've had surgery and you're given a pain pill, and it makes you feel really good, then you might be one of those 20%, that 1 out of 5 that's really at risk. And if you take a pain pill and it makes you feel nauseated and you feel yucky and you don't like how it makes you feel, then you're probably in the 80% that's not at risk. So the genetic risk is 50% of your tendency you cannot control.
Got it. Okay. Keep going. So there's the genetic component. What else is there? The factors that contribute to addiction?
Social components, like if you grew up in a family where there's a drug culture, where you're exposed to drugs, obviously you're going to have more likelihood of developing an addiction. If you expose a young brain to drugs, then those pathways become more established, and you're more likely to have problems as you get older, more likely to have problems with addiction. There's also economic factors. So we see really high rates of drug addiction in these coal mining towns where the economy's been devastated, where people don't have jobs. Some of these rural American towns that where their main industry in the town has been devastated have really high rates of addiction, and they have really high fatality rates from opioid overdose.
Okay. So socioeconomic factors, early exposure, social sort of drug culture, genetics.
One other big one is adverse childhood experiences, ACEs. This is big in the psychology literature. If you've had, as a young child, sexual or physical abuse, then that's linked to much higher risk for addiction later on in life. And there's some really good research that's showing those links.
Physical, sexual, is that what you said, abuse?
Yeah, physical, sexual, I would even throw in emotional abuse in that. Neglect.
Or neglect.
Yeah.
And why do you think those types of abuse would make someone more likely, just because it's malformation of the brain, disruptive, excessive trauma, PTSD?
Yeah, and maybe they develop unhealthy coping mechanisms to deal with the trauma. And so then when they're exposed to a drug that helps them feel good, perhaps that feeds into some of those unhealthy coping mechanisms. The psychology of the brain is so complex. And then when you look at brain development and how complex that is, and why someone who's been abused would be more likely to turn to drug abuse. I mean, it seems intuitive. I'm not sure how to fully explain it on a scientific level.
Okay.
Although I'm sure there's people that can.
So to summarize, consider staying away as much as possible from opiates and alcohol and other stimulants. If you have a close family history, are part of a social or familial scene that has a drug culture, stay away from it for sure in your early years, like you said, before he's 25. If you're in a poor socioeconomic status, it's a real risk. If you've been a victim of some sort of childhood abuse, or if you tend to be someone who just doesn't have healthy coping mechanisms generally, those are all additional reasons to avoid this stuff.
Yeah, and just one thing I want to clarify is that addiction does affect all economic levels in society. So even though I really emphasize some of these towns that have been economically devastated that have high overdose rates, you can't predict if someone's an addict based upon their income. So there are plenty of people, and I could give you plenty of examples of patients who are in very high profile jobs, who have very good incomes, who have very good family situations, who have basically the perfect life, and they're addicts.
So doctors, lawyers.
Absolutely.
So
I'm not saying that you can use these things to predict who's going to be an addict,
right.
Because people who are addicted come in all families and all walks of life and all religions and all cultures.
It's more about managing your risk profile, right?
Exactly. Yeah. And I think the most important thing, take home point, is avoiding that early exposure, because that is something you can control. If you avoid chemical exposure during your teenage years and early 20s, then you've really mitigated your risk factors.
Got it. Okay. So really quick, let's talk about alternatives just before we get into addiction and recovery. Let's just say someone thinks that they are at high risk or they just want to avoid the Russian roulette of drugs or alcohol. Let's start with opiates. Let's say that someone breaks their leg or hurts their knee or has back surgery and they just want to avoid opiates. You say that you provide alternatives. What are the types of things you provide or that others might provide to keep someone from going down a risky path?
Okay, so for most surgeries, you're going to be exposed to an opioid. It's really common to use fentanyl or Dilaudid or really potent opioids during surgery. So now if you tell an anesthesiologist, hey, I want to do my surgery without any opioid exposure, we can do that. Most of our anesthetics that we use to actually make a patient unconscious don't require opioids. And there's a lot of medications that we can use that are non-narcotic type medications that are good for pain relief. For example, gabapentin is a medication that's really good for nerve pain. And there's medications that can be used in the perioperative period that don't involve opioids. That being said, it's not the end of the world if you need some opioid around surgery. So to have a brief period where you need some fentanyl or some Dilaudid during a surgery or shortly after surgery, as long as, if you feel like you're high risk, if you just basically put limits on that and reduce your exposure as much as possible, then you're going to be in much better shape than if you go home with a prescription and stay on it for weeks or especially months at a time.
That's what I was going to say. It seems like when they knock you out for a surgery and then you come out of it, that sort of opiate use seems contextually different than if you're going home with a bottle of pills, right?
Absolutely. And the longer you're exposed after your surgery, so if you go from days to weeks to months, the more likely there is to be an addiction. So if you can limit that exposure to just hours or days, then you're going to be a lot better off.
Okay. And again, for those who, with the bottle that they take home, to list again the things that they can request that aren't opiates that can still manage the pain.
So there's a whole variety of things, from anti-inflammatories like ibuprofen and Aleve. Those can be very useful. Gabapentin is a medication that's really good for nerve pain. Lyrica is a very similar drug. There's also other classes of antidepressants and anticonvulsants that we use to help people with pain, things that are non-addictive. So, I could provide a list of probably 25 or 30 medications that are not addictive that can be helpful for pain. Now, just because they're not addictive doesn't mean they don't have side effects. They might cause you to be really sleepy, or, you may not necessarily be able to function in everyday life on some of these medications, but for a brief period after surgery, it might be a reasonable option if you want to avoid opioids.
A couple of comments or questions from our audience. To begin with, Tambi is mad at you. She says, "I can't believe you didn't tell me you were going to be on the podcast today." So yeah, that's from Tambi.
Tambi's a great friend, and I actually mentioned her. She's the friend that helped my wife through a lot of her struggles and has been a huge support to us through this process.
Shout out to Tambi. Okay, a lot of people are asking about specific drugs. So somebody asks about kratom, Kratom. That's Larry.
Don't know.
Okay, how about tramadol?
Yeah, so tramadol is a very mild opiate, and it also affects other receptors. It affects serotonin and norepinephrine. And so tramadol is less addictive than morphine and oxycodone and hydrocodone, but it can still be addictive. So just because it's a mild opiate doesn't mean it's not going to cause problems. So, so it's still something you need to be careful with. But, you know, if I had to choose, I'd choose tramadol over a lot of other types of pain medications, especially if you only need it for a short period of time.
Go ahead and list the most prescribed, most dangerous, sort of cliche, dangerous opiates, just so that people have kind of got a general list going.
So the most prescribed is probably hydrocodone in the U.S. The U.S. consumes huge amounts of hydrocodone, and that's like Lortab or Norco. Those are the trade names. Hydrocodone has the same potency as morphine. So 5 milligrams of hydrocodone is the same as 5 milligrams of morphine. And then stronger than that is oxycodone. And that's like, there's short-acting form like Percocet. And there's long-acting oxycodone, a 12-hour pill, which is OxyContin. And OxyContin has kind of become famous because of the OxyContin highway, and it's been pretty common drug of abuse over the last 2 decades. And then there's even stronger drugs like Dilaudid and Opana. These have kind of catered to the chronic pain market where people are in pain for decades and they need stronger and stronger drugs. And then there's drugs like fentanyl that are really potent. And fentanyl classically has only been used during surgery, like an injectable form or as a patch. But now there's a lot of illicit fentanyl being produced, and it's being laced in with heroin. And a lot of these deaths that we're hearing about are because people have been exposed to really potent fentanyl doses from heroin contamination or just illicit fentanyl use, and it's very hard to regulate the strength. So it's really deadly.
Okay. And how does it happen that both from a physician standpoint and a patient standpoint, where addiction is allowed to sort of develop? I remember 5, 10, 20 years ago hearing that the pharmaceutical industry spent billions of dollars marketing their products to physicians, buying them vacations, buying them junkets, showing up to the office and providing lunch to the entire staff, snowmobile trips and skiing trips and Caribbean cruises, all under the guise of training. But really it was prescription drug companies buying off physicians. So maybe that's extreme. Maybe that doesn't happen anymore. But talk about the business model for how physicians can become incentivized to overprescribe.
Yeah, I think most, all the activities you're referring to, we consider them unethical. So now there's very strict reporting guidelines. So if I accept, if I do a trip sponsored by a pharmaceutical or a device company to do training, which I do on occasion, they actually have to report that to a government website. And you can actually go and look me up and look at which companies have sponsored different things, and you can know how much support has been given to me from any various companies. So if Purdue Pharma was going to bring me lunch or bring our clinic lunch, they would have to report it, and you'd be able to, that would be discoverable.
Well, what's a website someone could go to for that?
I don't know off the top of my head, but it is a government sponsored website, and I could get that link for you later.
Okay, maybe send that to us. Okay, so you can see if doctors are being bought off, basically. How else might be doctors inappropriately or appropriately incentivized to maybe allow a patient to become addicted? How does that happen?
Well, I've learned a lot about this from my patients, specifically from the patients that I treat for addiction, because they'll tell me the things that they used to do to manipulate doctors. One is they'll tell you that they have 10 out of 10 pain and that they're miserable all the time. And as a doctor, you're feeling compassionate, you feel bad for them, and they say the only thing that helps is this medication. And so you may not have any other options. You may not have any other ideas. Everything else you've tried hasn't worked. And so you don't want to send this patient home without the treatment that they think is good for them. So a lot of doctors have good intentions, but they end up prescribing these pills over a long period of time and not really recognizing that the patient is addicted. And the patient may not recognize it either. A lot of patients don't believe they are struggling with addiction. They sometimes don't have insight into their own behaviors.
Right. And again, they're because they're starting to become addicted, they're going to want to say, even if they're fooling themselves, they're going to want to say how terrible the pain is because they want the drugs, right? And
Yeah.
doctors don't have a way to measure internal experiences of pain. And so is there anything a doctor can do to really vet legitimate pain versus illegitimate pain?
Yeah, I mean, you can't even really talk about pain in terms of legitimacy, because even an addict, in fact, I would say especially an addict,
Right.
will experience a lot of pain. So, in fact, that's probably the most intense pain. They're not lying when they say their pain's 10 out of 10, because if they don't have that drug and they go into withdrawal, it is extremely painful and it's real. And so for me as a physician, if someone tells me they have 10 out of 10 pain, I mean, that's their experience. They
Okay.
feel it's severe. And so I usually don't even question that. Now I can look at MRI results. I can look at CT scans. I can do a physical exam. I can determine if their pain seems out of proportion to their injury or to the pathology they have. But sometimes people who are addicted kind of know that process, and they know that there are certain things that you can't measure as well as others. Or you'll have patients, this doesn't happen so much anymore with electronic medical records, but years ago, you'd have patients bring in MRIs that they bought on the internet, and it's not even theirs, but it shows like a serious spinal problem, and patients would convince doctors to give them drugs based upon those images that were falsified.
Interesting. So a lot of gaming on the part of patients, right?
Yeah, and I think also some patients kind of develop these behaviors over time, and it becomes part of who they are. And it's not necessarily intentional or manipulative, but sometimes it kind of sneaks up on people.
Right.
One thing I want to be really clear about, because this is really commonly misunderstood, is that there's a big difference a clear difference between addiction and physical dependence.
Yeah. Talk about the sort of the chemical nature of addiction and dependence, and how the opiates work and how they interact with the receptors and that sort of thing, so that people can kind of understand what's going on.
Right. So John, if I gave you 4 hydrocodone a day for a year, and let's say you didn't even like the way it made you feel, or you didn't like, you never got high from it, you never overused it, but on schedule, you took 4 hydrocodone per day for a year and then just stopped, you would go into withdrawal. That's physical dependence. But through that year, you never demonstrated any inappropriate behavior. You never manipulated me as a doctor. You never manipulated your pharmacist. You never stole medications from anyone else. Just because you went into withdrawal when we took that medication away does not make you an addict. I would say in that situation, you're not an addict.
Okay.
You're physically dependent. Addiction is a behavioral problem. So addiction is really characterized by compulsive behavior and inappropriate behavior surrounding drug use in this context, okay? And even though the patient knows that this behavior is not good for them, they continue to do it in a compulsive fashion. So really, when I'm talking about addiction, I'm talking about more of a behavioral issue. And when I'm talking about physical dependence, I'm talking about the natural response of the body to a drug that's been administered over a period of time.
And does the dependence have to include negative symptoms upon the cessation of taking the substance?
Absolutely.
Is that the main sort of a criteria?
Yeah, or if you don't have it, you may feel some cravings, or you may start to feel sick, or like you said, you may have physical symptoms. Like in the case of opioid dependence, you'll have nausea and vomiting, flu-like symptoms, um, uh, increased urination, severe body aches. Most people who go through a withdrawal episode describe it as like the worst they've ever felt, and they just wish they would die. And they
So
just
it's
kind of,
worse. So opiate withdrawal is worse than the whatever condition they were medicating usually.
oh, absolutely. And this is one of the problems, is that if someone comes in with chronic pain and I treat them with an opioid, then and then we do that for a long period of time, then they may think they need the opioid because anytime they try to stop, they have severe pain. And usually the first place that pain will manifest is in the place where they initially had pain. So a lot of patients are kind of tricked by the drugs into thinking that
They still have
that's what,
pain, the
yeah, and
original
that's what
pain.
they'd feel like if they weren't on the medication, which is not true. That's just a withdrawal period. And to make matters even worse, there's a condition called opioid-induced hyperalgesia, where patients actually have worsened pain because they're on an opiate. Basically, exposure to that chemical over time makes their pain receptors more sensitive. And so a lot of my patients that I see who have been on opioids for a long period of time actually have worse pain than they would if they had never been put on the opioid in the first place.
So it
So
actually
I tell,
it makes the pain worse over time.
yeah, and I tell all my fibromyalgia patients this, and I'm sure we have some listeners who have been diagnosed with fibromyalgia. The worst thing you can do if you have fibromyalgia is get on opiates, because opiates will make your fibromyalgia worse. Opiates, long-term use of opiates will actually make your generalized pain worse. But patients don't recognize it because in the short term, it actually makes them feel better for a few hours. It relieves those symptoms temporarily, but over time, over years or decades, they're actually becoming worse and worse, and it contributes to reduced quality of life.
So for someone with migraines or fibromyalgia, sort of chronic back pain, what are the alternatives?
So like chronic back pain is really my specialty. We've got uh, the most proven things for long-term treatment of back pain and fibromyalgia: yoga, aqua therapy, core strengthening, basically self-management of your body and keeping your core strong and keeping your muscles strong. The patients who do that have better outcomes than patients who go the route of medication management. And that applies to a lot of conditions.
I've even heard that back surgery oftentimes leads to more back pain than if you just use things like exercise and core strengthening and yoga and stretching. Have you heard that as well? That sometimes back surgery actually makes the back pain worse?
Yeah, there's really good evidence behind this. The reason you would have back surgery is if you're losing feeling in your legs, if you have such severe spinal stenosis or such compression that basically the nerves are no longer functioning. Obviously, if you're losing control of your bladder or your bowels, the first person you want to see is a surgeon. But if you go in with low back pain and have surgery for low back pain, um, there's not a very good prognosis, meaning you may have as much low back pain or worse low back pain after your surgery than you did before. Now, obviously, there's success stories of people who had just axial low back pain without any nerve compression who had surgery who did better, but there's also a lot of stories and a lot of evidence that a lot of those patients don't do better and in fact do worse.
Got it. Okay. So, so the types of scenarios that are inappropriate for a physician, maybe necessarily to liberally prescribe opiates, again, you're saying, or fibromyalgia in many cases, chronic lower back pain. What other types of chronic or other types of pain, painful situations should someone just really not even, or someone should someone be really skeptical about receiving opiates for, other than what we've mentioned?
I'm going to generalize this in a way that I probably shouldn't, because every patient is different. Every situation is different.
Yeah.
We're always working toward improved functionality. Obviously, if someone is in so much pain that they're suicidal, I'm a lot more likely to aggressively treat their pain than, someone who just comes in who's, having a hard time. But what I'm going to say is, generally speaking, the evidence is pointing to the fact that we should only be using long-term opioid therapy for palliative type conditions. So,
someone dying.
Yeah, the most obvious is cancer pain, right? So there's very good evidence that opioids can improve quality of life in patients suffering from cancer.
Right.
There's also pretty good evidence that people, my patients with severe spinal stenosis who are toward the end of their life, might get a really good functional response from being on some opioids. And I've got a lot of examples of the little old lady who comes in, she can barely walk, she can't get out of bed, she's not taking any medications, and then I put her on a very small dose of hydrocodone, and all of a sudden she's feeling like $1 million. And at 80 years old, am I really worried about the long-term side effects of opioid therapy? Not really, because, it doesn't matter as much what's going to happen 20 years down the road, because she's probably not going to be with us anymore. The most important thing is that I help her maximize these final years of her life. So any sort of situation that I determine to be palliative, I'm much more likely to promote long-term opioid therapy, whereas any situation that's in a young, healthy person who has a painful condition or who's been through a trauma, or, I'm going to try to not use opioids if possible.
And instead use the other things you've already mentioned.
Yeah, and I mentioned like physical therapy and yoga and aqua therapy, water aerobics and things like that, but there's also injections that we can do. There's non-narcotic medications that we can use that are not addictive, that are better for long-term use. And I also put in spinal implants. I put in spinal cord stimulator devices where I can send electrical energy into the spinal cord and actually intercept pain signals as they travel from the low back and legs to the brain. And, that's a way to help people with pain that doesn't require opiates. So there's a lot of strategies that we have. A lot of patients won't come see me because I'm a pain specialist. What they don't realize is that my specialty is actually promoting alternative types of treatments that don't involve pain pills. But we still kind of have this old school way of thinking about pain, that if someone's in pain and they go to a pain clinic, they're going to get pain pills. And we definitely need to move beyond that as a culture.
Couple comments from our listeners. Jeremy writes, benzos, I'm assuming he means benzodiazepine. Is that the right?
Yes.
They said they ruined his life. Withdrawing was so horrible. He was only taking what the doctor prescribed. No one told him that when he chose to quit using them, his life would be literal hell. Any comments about benzodiazepines?
Benzodiazepine withdrawal is awful. And if I have a patient come in that's been on benzodiazepines for a long period of time, I'm usually encouraging them to get off of them, but I'm encouraging them to do it very slowly, usually over a period of about a year, especially if they've been on it for a long time, because the body becomes so physically dependent on the chemical, and specifically inability to sleep and the withdrawal symptoms. I would say they're not as severe as the immediate symptoms of opioid withdrawal, but they just last so long. And benzodiazepine withdrawal is also very dangerous. So it's like alcohol withdrawal. If someone's an alcoholic and they just stop immediately, they can have DTs. Benzodiazepines are the same.
What's a DT?
A delirium tremens, where like an alcoholic goes into withdrawal and it can be fatal if they don't.
It can be fatal. Yeah,
it can be fatal. So typically we think of opioid withdrawal as non-fatal, and benzodiazepine and alcohol withdrawal as potentially fatal. So
that's interesting. That's interesting. So that's a case where alcohol can actually be more dangerous than opiates.
Yes. Yeah.
Okay.
In that particular situation.
Yeah, and benzodiazepines. Christy writes, please note yoga is horrible if your issue is bulged discs. So that's Christy's feedback to us.
I would say I understand what she's saying, but the evidence actually does not support what she's saying. For bulging discs, degenerative disc problems in the back, yoga is one of the best things that patients can do. And in her situation, it might have been not good. But in general, the evidence shows that it's actually more helpful than most medication type treatments we offer, and maybe even better than surgery and physical therapy and all sorts of other things your doctor might offer to you.
Got it. She mentioned twisting. I don't know if that's an important distinction, yoga versus twisting.
Well, the interesting thing is most people think that when they have back pain that, we used to like prescribe bed rest to people. Well, now we know that that's probably the worst thing people can do. And so now I'll tell people, like, move as much as you can. I want you to keep working. I want you to keep moving. 80% of people will get better. And, in her situation, maybe the twisting actually worsened the disc bulge or kind of exacerbated things in some way. But generally,
okay.
The evidence is pointing in the other direction of what she's saying.
Jeremy writes, acupuncture helped his back pain and incontinence issues. Any thoughts on alternative medicine and acupuncture specifically?
Love it. Yeah, I'm a big fan of acupuncture and seeking out.
That's not woo?
Well, I'll tell you what, there's some good evidence for acupuncture, and it's so much safer, right? It's safer than being on a medication. I've not heard of anyone people can have side effects to acupuncture, but there's not dangerous side effects. So, if you have the means to try acupuncture and to try some of these alternative modalities, and especially like cognitive behavioral therapy and some of the psychological avenues, those are very good avenues to take in addressing chronic pain.
Got it. Okay. Great. Let's see. Patricia writes that acetaminophen with aspirin works great for her. So a vote for good old aspirin, and I'm sure Advil and ibuprofen are also useful for a lot of people.
Sure.
She's basically saying use tramadol over Norco. So vote for tramadol as a superior to Norco.
Well, tramadol is much more mild than Norco, so I would agree that if you've got to choose one or the other, it'd be better for you to be on tramadol and not on Norco or hydrocodone, just because it's a much more mild opiate.
Right. Okay, I'm going to ask a question I've already asked. Are there, you hear in the newspaper about these doctors that have these prescription mills where they're just raking in the money intentionally or knowingly overprescribing people. Does that happen still? How rare is it, or how common is it? I guess another way to ask this is how are their addictions being sustained? Because you would want to think that there'd be doctors that give a limited prescription and then stop, and they could be wise enough to know whether a patient's had enough.
Yeah, so typically we refer these clinics as pill mills, and in Tennessee there's been dozens of these shut down over the last several years. So there were doctors doing this, and a lot of these doctors weren't even pain specialists. They're in other specialties. They might retire and just open up this pain clinic, and whether or not their intentions are good, I'm not really sure. It doesn't seem like they are, because I don't know how some of these doctors can really feel like this is a good thing for patients. And when you look at the doses that they're administering to people, it's shocking how many pills some patients are getting. And they're getting OxyContin, oxycodone, Opana, and they're getting Xanax and muscle relaxers. And it's really devastating.
And doctors make their money how? Do they get a cut from each prescription, or is it just they charge for the visit?
Typically, these types of clinics are cash clinics, and they're just paying for the visit. So, whatever the dollar amount is, $200 a visit, and then a doctor's able to see, 50 or 100 patients a day, and they're raking in a lot of money.
So you can make a lot of money as a doctor that way.
Yeah, and you're also at risk of losing your medical license. So, but it's surprising. The state talks about how hard it is to shut these clinics down. For some reason, if doctors document things in a certain way and justify what they're doing in a certain way, it becomes very hard for the government to actually come in and shut them down. So some of these behaviors continue on, even though we know that how devastating they are.
Got it. So when it happens because they're hard to shut down, they're hard to regulate.
Yeah. But I will say in Tennessee, they are regulating very aggressively, and a lot of the clinics have shut down, and there's a lot of patients who cannot get their drugs. There's just not a source for their drugs anymore. One of the things you're seeing from that, some of the patients just get off the opioids. Other patients actually turn to the street and start getting into illicit substances when prior to that they never had.
Yeah.
And so the fatality rates, even though the prescription fatality rates are going down, the illicit drug fatality rates are actually going up. And so the overall fatality rates are still rising.
And that's okay. That's good to know. And that's what I think both of the gentlemen that I interviewed before said, is they just turned to heroin because it was cheaper.
Yeah. And it is. It's really cheap.
Is it bad that we're talking about it? Like, I have this in my mind, like, oh my gosh, I just gave people the idea, but I guess that's pretty obvious to somebody who's hooked on opiates. So do we run the risk of encouraging it just by talking about it? Or do you still think talking about it? Obviously you must believe in talking about it or you wouldn't be here, but.
Yeah. And if they'll stay online and catch the tail end of our conversation, then that'll be the most valuable thing, because what we're going to talk about is how you can get treatment and how you can get a hold of this problem, because there are really great treatment options available. And there's no need that someone needs to go to the street, because they can get treatment for their addiction, they can get help, and that's just not a good pathway to take.
Okay, so we'll get to that in just a second. Jessica writes, my mother is an opiate addict. I drink alcohol, smoke marijuana, and a little more, but I've never had an addiction issue. But as you said, alcoholics don't appear until later in life. What are the signs at late 30s that Jessica and others should look out for?
Anytime there's compulsive use, then it's a concern, or overuse. So if someone's going out and drinking so much that they make themselves sick on the weekend, or dealing with like severe hangovers, or drinking large quantities of alcohol every day, or obsessing during the day about the next drink, or drinking compulsively when your spouse doesn't want you to, or
what if you're on opiates? What if you're taking opiates to manage some pain? What's healthy, responsible opiate use, and what are the signs for overuse and addiction, or inappropriate use?
Yeah, I would argue that it'd be hard in like a young, healthy person to say there's any such thing as like healthy opioid use, even if it's prescribed by a doctor.
Okay.
There's serious risk and dangers. Not to say it should never happen, but you should understand that there are serious risks involved with that kind of medical treatment. I would say with my patients who are on opioids, I always ask them, do you ever obsess about when your next pill is due? Are you counting down the time? Are you looking like, okay, my next pill is due at 1, it's 11, how am I going to make it through the next 2 hours? Are you overusing? Do you find at the end of the month that you've got fewer pills than what you should have? Are you always calling like on the day, on the minute when your prescription's due, and really letting those pills control your life? And if so, that's not a way to live. And you may be showing signs of addiction. And there's other options, and there's help, and there's ways to get off of them. And I just don't want anyone to be living like that.
Yeah, those are really helpful signs. So just if you're really Johnny on the spot about your next pill and filling the prescription, those are all really good. If you're noticing that they're not lasting as long, that's all super good. It's also worth mentioning that you should put opiates in locked, safes or whatever, because as we learned from our past interviewees, kids and family members and even visitors to a home who are addicted will often go and go into people's medicine cabinets when they're in the bathroom and steal opiates, right?
Yeah. And, that happens. Even people you trust. If there's someone that's the most honest person in the world that you would just trust with your life and they become addicted, they're going to do things that you would not expect them to do. And there's a scientific reason behind this. And I think it's important to understand that this is not a moral failing of the individual. When you become an addict, your frontal lobe stops functioning. And the reason that is because the limbic system, the reward system, which is like the system in the middle of your brain, it completely overwhelms your executive functioning, which is your frontal lobe. So when someone's in the midst of an addiction, their frontal lobe, their executive functioning, their reasoning is not working. And so their emotional centers completely take over. And all they can think about is how to get that next pill, or how to get that next high, or how to prevent further withdrawal. So what I want family members to understand is, your loved one has not become a bad person. Just because your loved one stole medication out of your medication cabinet.
Or even if they're lying, or
Yeah,
hiding, right?
of course they're going to lie. That's what addicts do. And it's not because that you failed as a parent. It's not because they're a bad person. It's not, we need to look at this scientifically and understand there are pathways in the brain that have completely overwhelmed them. And if we treat the addiction, you'll see the old person come back. That person's not gone. And what you'll do is you'll see the old honest person come back, and the person that would, take the shirt off their back to help you come back, and the person that would never steal a medication from your medicine cabinet. So there is hope. Even though when something like that happens, it seems like there's no hope. But definitely lock up your medications. When it comes to pain pills, you shouldn't trust people.
And it's not a moral question.
Right. Exactly.
Okay. Got it. There's a couple people making comments about this perception that if it's a prescription, it's okay, it's moral. So Melissa writes, she has a daughter-in-law whose mother is hooked on Xanax and Ambien, but it's okay in her mind because they're prescription. I'm sensing sort of a nod to Mormonism and the word of wisdom, that somehow if it's if it's a hot drink, or if it's coffee and tea, even a cold drink, somehow that's bad. But if it's not explicitly mentioned in the word of wisdom, then fair game. And what people are saying is, or even if you're cautious, just because a doctor, this is what Stephanie writes, just because a doctor gives you a prescription doesn't mean you should take the drug. Talk about that.
Yeah, I think everyone needs to be very careful, and you need to understand the risks of these drugs. These drugs, the reason these pharmaceutical companies have been so successful is because these drugs are really potent, and they do what they claim to do. And there is good science and good physiology behind the mechanism of these drugs. They work. And because of that, there's risks associated with their use. And I ask all my patients, be very skeptical. Do your own research. Don't just trust what I say. Look at the long-term side effects. Look at the long-term risks. And the less you can rely on pills, for the most part, the better off you'll be when it comes to pain. Now, I'm not talking about like diabetes or high blood pressure or other medical conditions.
Right.
But when it comes to pain, if you can find other coping strategies, and I say this about sleep as well. Taking a sleeping pill might help for the short term, but in the long term, it's just going to cause more problems. So most people, unless they have like a really well-diagnosed sleep disorder or something, you're better off not starting down the road of taking sleeping pills. And I kind of think of pain pills as the same way.
And Stephanie says Xanax, in her opinion, shouldn't even ever be prescribed. Thoughts on anti-anxiety meds?
I tend to agree with that in terms of by general practitioners. I think if someone has like a really severe anxiety disorder to the point where they're not even functional in society and they're able to take a benzodiazepine and it actually helps them to function and hold a job, there can be a case made for that for sure. And I'm not a psychiatrist, so I don't want to overstep my bounds, but I definitely think that benzodiazepines are overprescribed. I would not suggest using benzodiazepines for sleep. And I think even some people start on benzodiazepines like Klonopin and Xanax after periods of like the death of a loved one, and they're using it to get through a grieving period, and then they never get off of them.
So a Xanax is a benzo.
Xanax is a benzo, yeah.
Oh my gosh. Okay, that's good to know.
Xanax, clonazepam. Xanax is alprazolam. Clonazepam is Klonopin. Valium, diazepam. These are all benzos.
Oh, wow. Okay. Because I've had people joke, oh, I need to take another Xanax. And it sounds like that's not something to joke about.
Yeah, just do an experiment. If you're an active Mormon, go in Relief Society, just ask if anyone has a Xanax and see how many women reach in their purse.
You think there's a lot?
Probably.
It's overprescribed.
Yeah.
And it's dangerous, you're saying?
Yeah, I mean, for sure. It's especially dangerous. It's especially dangerous when combined with opioids. It can be fatal. It's dangerous in withdrawal, and it's dangerous for long-term use in terms of long-term side effects and not promoting quality of life.
Got it. Okay, that's good to know. All right, let's talk about recovery. There have been a lot of questions about the various medications or drugs available when somebody is an addict or is trying to recover from being an addict. So talk about how someone can get better when they are addicted to opiates.
Okay, before I do that, I want to share just a few stats with you that I think you guys will find interesting. Utah is 7th highest in opioid overdose.
Okay.
7th highest. Okay. So, and that's a 2015 statistics. So, more up-to-date statistics aren't available yet. In Utah, opioid overdose outpaces deaths from firearms, car accidents, and falls combined.
Oh, wow.
So there's more people dying of opioid overdose than in car accidents and from firearms.
Wow.
About 1 person a day dies in Utah from opioid overdose.
Wow.
In the U.S., about 100 people die a day from opioid overdose. It's like a commercial airline falls out of the sky every day in the United States, just from opioid overdose.
Wait, you said how many?
100.
Okay.
In the United States.
Okay, yeah, that's about a commercial airline a day, yeah.
Yep. Since the year 2000, 183,000 Americans have died from opioid overdose.
Wow.
183,000.
That's
in Vietnam, 58,000 soldiers were killed. So 3 times the number of Americans have died in the past 16 years from opioid overdose than died in the Vietnam War.
Got it.
So this is a massive epidemic. This is the modern medical epidemic of our time.
Yeah.
And one thing I want to say is we got to get rid of the stigma. If we don't start treating this, it's going to continue to get worse. And if it hasn't affected you yet, it will.
Either yourself or someone you love, you mean?
Either yourself, your sons, your daughters, your parents, your loved ones, your spouse. If it hasn't affected you yet, it will. And I'm guessing most of the people that are listening to this, it's affected in some way.
Okay.
Including myself.
Okay.
Okay, so we're talking about treatment.
Oh, well, really quickly, do you have a sense for why Utah is in the 80th or plus percentile in terms of deaths?
I don't know. I was looking at the national statistics on this, and the top state, I think the top state was West Virginia. And then
That's
it's
the
kind of
coal
like,
mining, the socioeconomic kind of theory,
yeah, I
right?
think so. And they're way up there. They're like double the next, the second on the list. But then it's kind of scattered all over the map, and I'm not really seeing any sort of clear religious, it's not like all Bible Belt in Utah. It's kind of all over the place. So I don't really know. I tried to figure that out before doing this interview, and I
Some are
kind
going to
of,
want to just say, "Oh, well, Mormons are more depressed because they don't, they don't cope well, or they, use band-aids, drugs as a band-aid, and they don't talk about things openly, and it's a shame culture." And you could probably find someone who's angry at the church, who's going to just find everything that's wrong, the LGBT problem or whatever, and they're going to blame suicide on those Mormon related things. Is that fair? Is there not fair? Is there anything to it?
yeah,
Is
I mean,
that
I don't know. I don't know if it's fair or not, but I just don't really think there's any evidence behind that. So I try not to jump to those kind of conclusions. If, you know, if, there may be associations there, but it's a very complex issue. And it's not like Provo, Utah has the highest rate of opioid deaths out of the whole state. The highest rates are in towns where their economy's been devastated, and Ogden has a fairly high rate. So it's not necessarily like the Mormon centers that are really suffering the most. So I'm
all
just
right?
not.
Someone could say the Mormons treat the non-Mormons so badly that they've got.
Well, maybe that's true. I don't
And I'm
know.
not fishing for this. I actually like it when myths or unfair characterizations are dispelled. So I'm not fishing for it. I'm just trying to
And
address what some would want to say.
yeah, and it could be an issue of prescribing habits. It could have to do with state regulations. It might not have anything to do with religious factors at all. I'm just not sure.
Okay, that's fair. That's good to know. Okay, so recovery. How does someone get better?
Okay, so the Alcoholics Anonymous and Narcotics Anonymous model have been around for like 80 years, right? And we could go out and find plenty of people that have gotten better using AA and NA. Would you agree with that?
Yeah, sure. People swear by it because they have sponsors, someone looking after them, accountability, regular sort of sessions that provide support, a sense of purpose, the mantras, the steps.
So what?
It was so respected that the church even tries to have their own version of it, right?
So in regard to opioid addiction, what do you think the failure rate is of Narcotics Anonymous and abstinence-based programs like it? What would you guess is the failure rate?
High.
Yeah, like probably about 90%,
Wow, that's super high.
right? Now,
So Narcotics
according,
Anonymous is not the best approach.
and that's not what I'm saying. I'm saying Narcotics Anonymous alone
Okay,
is not the best approach.
got it.
So if you have a loved one that is struggling
Oh,
with
wait, Jessica's asking how you define failure.
failure, would be relapse.
Okay, that makes sense.
And we're talking about repeated relapse, people who do not stay in the program
All right.
and who don't come back to the program and who fail.
Okay.
And the statistics are going to vary. Some people are going to say 70% failure up to 90-some% failure.
Okay.
Okay.
Yeah, there's always a range.
But generally 7 to 9 people who start the program are never going to finish.
Okay.
Okay. And some of those people in regard to opioid addiction are going to die from overdose.
Right.
Okay. So if you have a loved one, someone you care about, and you're encouraging them to get treatment, telling them to just go to NA or read the Bible more or go to some abstinence-based program is not the best advice.
Okay.
And if I ever have a child who has an opiate addiction, knowing what I know now, I'm going to get them into a medication-assisted treatment program, MAT.
Okay.
And what this means, medication-assisted treatment, is that we use medication to treat the cravings and the addiction, and we combine that with the psychological resources, cognitive behavioral therapy, psychotherapy, and that also goes along with the NA and the AA model combined. What happens though is a lot of patients go to NA and they're feeling guilt because they're also receiving a medication to treat their addiction because they're considered not clean, right? And so if family members are contributing to this guilt about a patient being on a medication to treat addiction, then it's really counterproductive. So what medications am I talking about? Mostly I'm referring to Suboxone because that's kind of the latest and greatest medication used to treat addiction. The older clinics that are still around are the methadone clinics. Okay, but there's a big difference between methadone and Suboxone. Methadone is a full opiate. It's just really long acting. So what a methadone clinic is doing is it's giving an addict a dose of methadone every day that they can take, and it basically keeps them from going into withdrawal, and it's so long acting it doesn't make them high. And so they just maintain on this full opiate, and hopefully.
How is that better? How is that better than what they're doing?
Because it's so long acting, they're actually able to function, and it gets them off the streets, right? So instead of using heroin and shooting up, they're using a controlled medication, but they're still on an opiate. But it's much better than being on methadone is much better than being on heroin or being out on the streets. And a lot of people who go to methadone clinics are able to have full-time jobs. They're able to be good parents. They're able to function. And one of your previous guests talked about how he was going to a methadone clinic. I think it was Thomas.
Right.
And he was having a good response.
Okay.
And so the last thing I would do is tell Thomas to stop doing that.
Right.
Because it's working for him.
Right.
And now, ideally, at some point, he'll be able to slowly wean off the methadone and get that behind him. But we don't want to get him off the methadone at the risk of him relapsing.
Got it.
Now, Suboxone is a partial opiate. So it's a very unique type of drug in that it's only partially activating the receptor.
Mm-hmm.
And so it's keeping patients from withdrawing, and it's satisfying those cravings, but it's also not having the same effects of a full opiate. So it's a really cool drug in that it's preventing relapse, but it's also not creating the euphoria and some of the problematic behaviors that a full opiate was.
Okay.
And another unique thing about Suboxone is that we can prescribe it in a 30-day supply. So you can go to the pharmacy and pick it up, and you've got your 30-day supply, and you don't have to go back to the doctor for, until the next month, okay, as opposed to going in on a daily basis. So people who are in a Suboxone program who also are doing an NA program or doing psychotherapy or cognitive behavioral therapy or meeting with a psychologist and working on coping skills, that combined is the most effective way to treat opioid addiction. And if someone's really in the throes of addiction, they should be seeking out a program like that. And I would say the evidence is not in favor of an abstinence-based program. So the reason why I'm emphasizing that so much is because here in Tennessee, where I am in the Bible Belt and probably in Utah, people are all about abstinence-based programs. It's not science. It's not evidence-based. It's really lacking in one of the key elements that people need to recover.
Got it. Do you have any sort of disclosures about the company that makes Suboxone and your relationship? Or I'm not making any accusations. I'm just wanting to make sure we have full disclosure.
No, I'm not a shareholder, and I don't have any financial interest in this discussion at all. So, and I should be clear, Suboxone is a trade name. The actual generic name of the drug is buprenorphine/naloxone. Buprenorphine is the drug that I'm talking about. That's the partial opiate. And the naloxone is put in there as an abuse deterrent to keep people from injecting it or doing inappropriate things with it. So it's a combination drug. But there's also other trade names would be Bunavail, Zubsolv, and then Subutex is the name of the drug without the naloxone, just the buprenorphine. in it would be Subutex.
Okay. Anything else about that treatment, whether it's somebody learning for a loved one or somebody who's addicted themselves? Anything else you want to say about? It sounds like what you're saying is Suboxone or some derivative thereof, plus either Alcoholics Anonymous or Narcotics Anonymous or psychotherapy is the way to go. It's
Absolutely
better than methadone overall. Anything else you want to say about that in terms of like how to maximize the chance of it being effective?
So one common thing that I hear family members say, or even I hear doctors say this, they'll say, oh, he's just trading one addiction for another.
Or someone else said that they're just using it as a crutch.
Right. Okay.
Yeah.
So this drives me crazy, right? Because this patient has a severe disease that could very well kill them. Okay. And we have a treatment. Okay. Now, will a patient become physically dependent on Suboxone? Yes. A patient will become physically dependent on Suboxone. But as I mentioned earlier, there's a difference between being physically dependent on something and addicted. Okay. So a patient on Suboxone, I'm going to give you an example. A girl I treat for addiction, she's in her late 20s and she was on the streets. Okay. She was doing heroin, IV. She was prostituting herself to pay for drugs. She had lost her children and she had no hope for a future. She'd failed rehab, inpatient rehab, 2 times. Okay. She comes in and we get her going on a medication-assisted treatment program where I start her on Suboxone, and she is also doing pretty intense psychotherapy twice a month, where she's learning about her past and she's learning better coping mechanisms. She's learning how to think more positively. She's learning how to eliminate negative relationships in her life. That person on Suboxone she's working for a maid service full-time and has been promoted to being a manager. She just bought a car and a house. She's got her kids back, and she reports that she has a good relationship with her boyfriend and she's living a fulfilling life. Are you going to tell that patient that she shouldn't be on Suboxone because she's just addicted to some other drug?
Right. Yeah, that's pretty obvious.
Yeah, I mean, it's an extreme example, but that's what people's family members say, and it's like you're just thinking like you're living in an alternate universe here. Like, you've treated this disease and this patient's gotten better and they're having this fantastic functional response, and their family members are shaming them about it and encouraging them to get off it because they think they're just addicted to another drug. Right?
Is there duration, an average duration where someone goes from Suboxone and then kind of weans off it?
Well, in the example I used, someone who at a young age was using IV heroin, I would never encourage that patient to get off the Suboxone.
So they might take it for the rest of their life.
Absolutely.
And for you, that's not a problem.
I'm good with it because their relapse risk is so high. If they get off the Suboxone and they start experiencing cravings, their chances of relapse into heroin and their chances of death are very high. Now, if this patient comes in and she really wants to get off of it, I'll just recommend a really, really slow wean off of it, and I'll just keep a close eye on her. And if she starts having cravings, we'll bump the dose back up.
What's slow?
Probably in her case, someone in that severe an addiction, probably 2 years,
Okay.
a year to 2 years.
Wow. Okay.
But let's use another example. Someone's taken hydrocodone, by mouth, 40 milligrams a day, like 4 times a day, and they start to lose control, and so they get on Suboxone as a way to treat what's developing into possibly an addiction. That patient, I'm not going to recommend stay on Suboxone forever. I might recommend like a 6-month slow taper off of the medication. So it all depends on the individual patient and how severe their addiction is. But that's really a discussion I'm having with the patient, and it's not something I'm pressuring them about. It's not something I want the state to regulate. It's not something I want the insurance companies to regulate, because we need to have the freedom to continue treatment if a patient needs it.
Right. Got it. Okay. So are there other factors that help determine whether someone successfully, passes through treatment and recovers versus not, in addition to choosing the right treatment?
I think them becoming as functional as possible is really helpful. So anytime I hear that someone's gotten a job and is holding a job, that's a really good sign that they're doing better. Family relationships are important. It's important for people to have good support groups. It's important for people to have friends who aren't going to impact them in a negative way. Guilt and shame are really devastating for an addict. And so family members need to be really careful about that.
What does that look like? Encouraging or increasing the guilt and shame versus not? What does that often take the form of?
Reminding them of their past behaviors. Basically, some of the behaviors that we talked about, like maybe they stole a medication or maybe they lied, bringing that up, or making them feel unworthy or like they're not a good person, making them feel like because they have to be on Suboxone, they're not clean, making them feel like if they would have just gone to church more or read their scriptures more or prayed more, that they would have gotten better.
It sounds like once they reach the level of an addict, you treat it like diabetes.
Exactly.
It's just a medical condition.
And as a parent, if you have a type 1 diabetic as a child, you're not going to tell them not to take their insulin.
Right.
And you may have a child who's an addict who needs to be on a medication, and they may need to be on it for the rest of their life. And you know what? That's life.
What if irresponsible, and I'm playing a devil's advocate here, what if irresponsible decisions led to the addiction? What if it wasn't just I was sick, I had back pain, and then I got addicted? What if it was like you went to parties with bad people and you lied and you weren't living the word of wisdom and you were not in church and you started with marijuana and then it grew and slippery slope? And what if the person really is legitimately responsible for making some poor choices that led to the addiction? What would you say to a family member that wants to sort of say, hey, this was you made bad decisions that led to this, versus them being more of a innocent victim as a result of genetics and a doctor's prescription? You know what I mean?
So this is Tennessee, so everybody has type 2 diabetes. So I'll say, well, how's that different than you? Because you got type 2 diabetes because you didn't exercise and you didn't eat right. And you know what? As your doctor, I'm not going to treat your type 2 diabetes because you made poor decisions. And you know what? You've got this disease. Tough luck. That's life. You should have made better decisions when you were younger. Like it's counterproductive, right? We all do stupid things.
Yeah.
So you know what? So what? Like just reminding them of all the stupid things they did over and over again is just going to make them feel worse. And these are triggers for addicts, right? The guilt, the shame, feeling worthless. These are triggers that make an addict want to use drugs, right? So causing feelings like that can be really devastating for someone who's in recovery. So we should be really positive. We should look toward the future, not toward the past. And we should help people recover in a healthy way, get better coping skills, find better friends, be more positive with their thinking. And if we as family members help the recovering addict do that, then it'll really help a lot.
Okay, so avoid guilt and shame. Incorporate family and friends support, social support. find the right treatment. Anything else that is associated with a higher chance of recovery?
Um, I mean, that's about all the evidence-based ideas I have. I just
Okay.
think living an authentic life and being open and honest with your loved ones, with your spouse, is really important. You got to get it all out there. It's like an abscess that's got to be drained. Once you get it out there, you're going to be able to heal. And so being open like that is another step in the right direction.
Yeah, that's interesting because in that case, some would argue religion doesn't encourage authenticity or openness. Um, and in that way, maybe isn't always good um, for someone who's an addict. And I would say in the people that I've interviewed, they've also said that being open and candid, getting your problems out, again, seeing a therapist or talking to someone can really help make the difference.
Yeah, and if you're going to church and everyone's prim and proper and everyone seems like they have the perfect life and you're there and you're a recovering addict and you're trying to sort through all your problems, that may make you feel like you're not worthy and you're not adequate of this congregation, when in reality everyone's got issues, right? So if we're involved in a community where everyone's trying to cover up their issues and everyone's trying to hide their issues and everyone's trying to make it seem like they're perfect, then that may not be a healthy place for an addict to be.
On the flip side, let's say you have a healthy church experience, maybe your ward could be a really positive resource for you. Is that true?
Yeah, absolutely.
And
Absolutely.
and maybe that's more often the case. And also, I remember one of our interviewees just saying that the bishop helped pay for his treatment. That's kind of nice, right?
Yeah. Yeah, sure. And bishops can be really helpful. And I hope bishops get training and know the proper resources and are encouraging people to go to evidence-based treatment solutions. And, I think the church is definitely moving in that direction. Um, and it's variable who your leaders are, but they can be a really valuable resource.
Got it. Okay, really quick, because I'm at the point where I have to go pick up my daughter or my
Okay.
son. Uh, any other things you would say? What about somebody who's poor and or jobless? How do they take advantage of Suboxone or these clinics if they are poor and unemployed?
So I did find out that Intermountain Healthcare has a free MAT program, medication assisted treatment program. So that may be available to people. And I think we need to really push our state governments and the federal government to provide treatment for everybody. And that would be money well spent. And we're working on that here at Vanderbilt and on a local level. And I know there are people working on that in Utah, and there may not be resources for everyone right now, but we all need to be pushing in that direction to make sure that resources are available to everybody who wants treatment.
But there are clinics that offer discounted or even free support. Is that true?
Yeah, and also the pharmaceutical companies have programs where if you have a limited income, they will sometimes provide medications for you for free. So you can look into those programs. Usually they're pretty accessible online, and you can determine if you qualify.
Okay. And then maybe as a second to last question, let's say someone you love is addicted. Is there anything you can do, or does it really have to come from the addict themselves hitting rock bottom?
I think it depends on the situation, but if you're a family member and you know about these resources and you can utilize the resources when that person is in a vulnerable situation or when they've hit rock bottom and support them in whatever way that you can, then it's going to be a game changer. You don't want to take your loved one to the wrong program or to a non-evidence-based program and have them fail that first time or that 10th time. You want to take them to a program that's based on science and that's based on evidence and that is going to have a higher success rate than programs that might be abstinence based alone or strictly religious based.
Okay. Um, Anything else as it relates to the addict's desire versus the concerned family member or friend's desire.
Yeah, just love them and realize sometimes people are going to fail, sometimes people are going to relapse, and hopefully it's not something that kills them or harms them seriously. And sometimes, like with quitting smoking, sometimes it takes several attempts, and try to stick with them, and they're going to do things that are really awful, and they're going to say things that are awful, and they might steal your money, and they might do things that really hurt, but there's still hope that you can have the person you knew back. And there's hope that with modern treatments that we can get through this and get people better. And I've seen it. I'm telling you, I've seen it dozens, probably hundreds of times. People who have really serious addictions, specifically opioid addictions, get better. And there is hope.
And again, Suboxone plus some sort of therapy or talk therapy, social support is the way.
Yes.
All right. Well, Dr. Dan Lonergan, I really appreciate you coming on Mormon Stories, not just to talk about your own faith journey, your mixed faith marriage, but also to deal with this epidemic that's hitting the United States and maybe the world, but even Utah and Mormons at a higher rate possibly than the non-Mormons. So please send us any links or resources you want. We'll add them to the post. And
Okay.
and I just want to thank you so much for all you've shared with us. I believe it's going to save lives. And I want to thank you for being willing to share. Any final words?
No, I appreciate you having me. I hope it does save some lives. I hope some people listening will find this helpful. And I appreciate you having me.
All right, Dr. Dan, thanks so much. I want to thank everyone for tuning in. We had listeners join us for the whole episode. Lots of good feedback and questions from our listeners. So I want to thank everyone for joining us live, for their comments and questions. For those who support Mormon Stories, the Open Stories Foundation, thank you. For those who don't, please go to mormonstories.org or the Open Stories Foundation and start a $10 or $25 or $100 a month donation. Those are what keep us alive and that allow us to continue. We sure appreciate the support. Want to thank Amy Grubbs and Cody Layton of the Open Stories Foundation. They're our staff that keep things going along with the Open Stories Foundation board. Please tune in again for more Mormon Stories in the future. We sure appreciate all that everyone does. And if you have ideas or suggestions, or if you want to appear, please email us at mormonstories@gmail.com and let us know of your ideas, and we'd love to consider them. All right. Thanks, everyone, for joining us. And again, thanks, Dr. Dan. Hope to have you on again sometime soon.